I would like to invite Dilip to give his takes on leptomeningeal data. And the reason why I had chosen Dilip is Dilip has done an extensive review on leptomeningeal metastasis. He is the person who analyzed the data of leptomeningeal disease. So over to Dilip for his expert comments on leptomeningeal disease.
Hello, good evening, sir. Thank you, sir, for the for the invite, and I thank the lung cancer year-end review team for inviting me for this workshop. Basically, Vijay sir has almost all the these things available, all the these things on. So basically, the diagnosis based on neuroimaging, clinical findings, and CRSF analysis, and the type of there can be either it can be divided into type 1 or type 2, as sir had pointed out, and based on neuroimaging findings, it can be divided into type A, which is a typical linear abnormalities in MRI, type B with nodular abnormalities, or type C with both linear and nodular abnormalities, and type D in which patients have no MRI abnormalities except hydrocephalus, and it can be divided into confirmed, probable, or possible and no evidence for. So the basic goals of therapy for this leptomeningeal mets is to prolong survival with an acceptable quality of life and to prevent the delay neurological deterioration. And the prognostic factors, most importantly, are performance status, type of primary tumor, pathological and molecular characteristics, protein level in CSF, concomitant brain metastasis, administration of systemic or intrathecal pharmacotherapy, or initial response to treatment, and the status of systemic disease. So there are actually, as told before, there are lack of proper randomized trials for determining what is the exact type of treatment which is required for a leptomeningeal mets. So basically, first is the intrathecal pharmacotherapy, which can be which actually has been covered extensively. It can be either a methotrexate, liposomal cytarabine, or thiotepa. And there is no actual consensus on the optimal dose, frequency of administration, optimal duration of treatment, and combined intraCSF therapy, that's a triple IT, is not superior. And there have been few case reports of use of intrathecal pemetrexate, but it has not been used in clinical practice that often. And coming to systemic pharmacotherapy, if there are elevated CSF protein, actually indicates a disruption of the blood-brain barrier. So systemic pharmacotherapy can work to a certain extent in such cases. So systemic agents. So when you diagnose a leptomeningeal mets, you should look at the other sites of progression also before alluding to the treatment of leptomeningeal mets alone. So systemic agents should be selected based on the primary tumor and its molecular characteristics. And for lung cancer, basically platinum-based chemotherapy with combinations of bevacizumab may be beneficial as per few case series. And as alluded to, as told before, the Bloom study, which used osimertinib in EGFR mutant cases, has shown good results, and it can be used in such driver mutation cases. And new generation ALK inhibitors in ALK positive cases like brigatinib and lorlatinib are expected to improve outcomes, even though we don't have data as of. And coming to immunotherapy, when you come to immunotherapy, there's a recent this thing showing that pembrolizumab has shown impressive response rates in and it reduces the CSF aneuploidy of ctDNA in leptomeningeal mets. This is a study by Naidu. It has been recently published in Immunotherapy of Cancer journal. And there have been also used a few case reports as use of intrathecal immunotherapy by Glitza et al., who used the intrathecal nivolumab, but there are no clear data to draw any definite conclusions. So coming to some real world evidence based on the ESMO classification, the Lirun et al. Had recently published a retrospective study of 254 patients of newly diagnosed leptomeningeal mets from solid tumors. Patient with confirmed when they divided them into confirmed, probable, possible, the confirmed leptomeningeal mets had a worse outcome, and type 1 patients had an inferior outcome compared to type 2 patients. And the nodular disease, which was on MRI, which was detected on MRI, was a negative prognostic factor in type 2 leptomeningeal mets. And on multivariate analysis in that retrospective study, the administration of intrathecal pharmacotherapy or systemic pharmacotherapy was associated with improved outcome in type 1 leptomeningeal mets, but not in type 2. So basically, to conclude, what I want to say is leptomeningeal mets is still a ocean which is still needs to be explored more. And because our cancer patients are surviving more due to the better availability of therapy for systemic disease, so we'll see more and more of leptomeningeal mets in the future. So, so there is a need for improving the survival and the outcomes of such patients. Thank you for the opportunity. Thank you.